Hi everybody, I'm Ian Davis, Chair of ANZUP Cancer Trials Group, and I'm speaking to you from the 2024 ANZUP Annual Scientific Meeting. It's a great pleasure to have with me today Professor Bertrand Tombal. Bertrand is a urologist from Belgium, well known for his role in EORTC and a stalwart for ANZUP. So welcome Bertrand, great to have you once again at
My
our
pleasure,
annual
always,
scientific meeting.
Always the happy top of my year.
You gave us a great talk today on value in healthcare. Can you tell us a little bit about what you mean by value?
So value means a lot of things, okay? So basically it's asking the question, does it worth it? Okay, so no, the worth will change whoever you speak. If you speak of worth for patient, it may be in some country how much I have to pay for it, but like in socialist country like I'm living is what did I get out of it? Am I going to live longer? Am I going to get less side effect? Am I going to get a better quality of life? And then in Europe, especially, value is how much we as a society, we agree to pay for that treatment. And it's true that if you take that angle on are these treatments really beneficial for the patient, and you agree on a standard definition that they should live longer, better, with less side effect, we must recognize that many treatments we use don't have such a very high value. And I think that a good example, the number one example was basically radical prostatectomy in low-risk cancer. It never says that you don't cure these patients. It says that, yeah, okay, but they won't live longer, they won't live better, and they're going to have a poorer quality of life. So no, there is a lot of work from European Commission, HTA bodies, and all of that to try to measure it. ESMO has been the leading, they came with this maximum clinical benefit scale, and looking basically at OS when you have it, PFS when you don't have it. And the observation is that actually most of the drug we use, they rate poorly. And still with prescribing a lot of drug, we don't have any big benefit, and that probably we should start to be more value conscious when we prescribe. Yesterday at the very nice oral abstract session, there was this great poster on how the change in the timing of prescribing immunotherapy in metastatic renal cell carcinoma has evolved. You see, really, it's not going the good direction. We give it earlier and earlier and earlier, although the value has not increased. And you could even say that because, as they say, patients don't live longer, the value decreases because we're exposing more patients to unexpected toxic drugs. So that's something I got a personal interest. That's very common in Europe. And I think we start to, but I also believe it's a corporate responsibility. It is our role to do it. And for research organizations like ours, it's also a great opportunity to provide real data.
So a lot of people thinking about value go straight to cost, and that's obviously important. The magnitude of clinical benefit scale is obviously talking about some of the other benefits that have been shown from clinical trials. At what point do we get the patient voice into what's meaningful for value?
So I think that there is, to me, the important link is that when we try to quantify benefit, we do it as doctor. For instance, we would say, wow, we have a 6 months overall survival benefit with minimal toxicity. Then you show that to a patient and you say, wow, first, toxicity is not minimal. Second, 6 months, honestly, what is 6 months? So what we try more and more, and I must say it's the regulator, EMEA is behind that, is try to know we would measure the benefit, but stop telling how much that benefit or detriment is relevant for patient or not. We need to find a way to put patient in that discussion. A good example is here we are redesigning a trial in intermittent androgen deprivation therapy. And we had people say, oh, you're going to lose 6 months of overall survival. Then we start questioning patient. And many patients say, if you can guarantee we have less side effect and a better life, we take it. So we need to create model so that at the inception, what a patient would believe, and I'm come back to the pembrolizumab example because it's a great example. Would you dare doing a trial to show a 5% benefit at 10 years with 2 years of poor quality of life. And my worry is that we would stop a lot of these trials very early on. So to me, that's something I still have 5 years to go. I would like to change. It's that it's not us, physician and statistician, who decide that is a benefit. No, we should ideally execute a trial whose anticipated benefit has been discussed with the patient from its inception.
And they should be involved in the conduct of the trial and telling us how to interpret it.
We had a very nice poster at ASM with the Japanese Association of Oncology, where we look at how we involve patients. We ask them usually to do 2 things: review the informed consent and help us promoting the result of our trial. But we never ask them whether does it make sense? Are you happy with the benefit? So we need to involve the patient much earlier on. Get their idea, and most importantly, talk about the benefit and the design from inception.
We're very fortunate in ANZUP to have a great consumer advisory panel giving us that sort of information, but it's so critical for every patient to find out what truly are their goals of care, what is important for them.
That's what I've been always admiring. I said, your consumer engagement. To me, there are only 2 examples where there is such a high consumer engagement. It is Cancer Research UK and the academic trial done in UK and here in Australia, because you can feel when I'm attending the SAC or whatever that patients have their voice from the beginning. And sometimes it's very funny to be an outsider, somebody discussing a trial, and you see the consumer who seems to say, okay. So I think in 2-3 years, they're going to tell you, okay, nice idea, but we don't want it.
They're happy to tell us that.
They're not yet fully happy to tell it, but it's going to come in 2-3 years.
Look, thank you so much, Bertrand. Wonderful talk. Fantastic to have you part of the meeting again.
Thank you.